My name is Shelley Adler. I'm the director of the Osher Center, and I am welcoming you to Grand Rounds at the UCSF Osher Center for Integrative Health. It's my great pleasure today to introduce two speakers, Dr. Meghan Jobson and Dr. Juliet Morgan. I will introduce them in alphabetical order. Dr. Jobson is an internist and an integrative palliative care physician who practices at Laguna Hospital and Rehabilitation Center here in the city. In her clinical work, Dr. Jobson combines concepts from integrative medicine, exercise and movement practices, nutrition, conventional medicine, and neuroscience, truly integrative. She earned her PhD in neuroscience from the University of Utah and her medical degree from UNC Chapel Hill. I'm also pleased to share that Dr. Jobson participated in our Integrative Medicine Clinical Scholars Program here at the Osher Center with our clinical fellows for 2 academic years. And along with Dr. Morgan, she developed and co-facilitated COVID recovery groups during the pandemic. Dr. Morgan is an outpatient integrative neurologist and psychiatrist at CalPsychiatry, a private practice specializing in holistic approaches to mental health. And she's also a volunteer clinical faculty in the Department of Psychiatry at UCSF. Her clinical practice focuses on the integrative treatment of neuropsychiatric and psychiatric illnesses. Dr. Morgan graduated from Duke University and went to medical school at Baylor College of Medicine. I am again pleased to share that Dr. Morgan also completed our Osher Collaborative Faculty Fellowship in Integrative Health, and she worked with Dr. Jobson in developing and co-facilitating the COVID recovery groups. So one last bit of housekeeping. After the presentation, we'll have about 15 minutes for discussion. You can submit your questions to me by way of chat, so you can have them asked and then focus on other things. And you're also welcome to unmute and go on video to ask live in real time during the discussion. Lastly, I want to planning committee, Drs. Anand Dhruva, Selena Chan, and Sarah Patterson. And now please join me in welcoming our duo of speakers, Drs. Jobson and Morgan. Meghan, you are, yes, muted.
Can everyone hear me? And can everyone see the slides?
And still no sound.
Can anyone hear me?
I can.
I can hear you.
Okay.
I can hear you. We can hear you and see the slides.
Okay, perfect. Then I will begin.
See, we shouldn't have practiced ahead of time. Let me see what I can do at this end, folks.
I think maybe Shelley can't hear. Is that? Should I just go ahead?
I think you can start. Yes, go ahead.
Hi. Good morning. Thank you for joining us. My name is Meghan Jobson, and I'm here with Juliet Morgan. This morning, we're going to be talking about integrative medicine skills for long COVID recovery based on our experiences leading a long COVID integrative skills support group in the fall of 2002 to spring of 2021. And just give me a moment. There we go. We have no financial interests or other relationships, but we do have a book that we're publishing that relates to our work with patients with long COVID. Our work with long COVID patients brought up a lot of themes and issues that came up during our collective trainings and our experiences with our own health and the health of our loved ones and people in our community. And what it led to is a book that will be coming out with Hachette Publishers in the winter of 2022 about long illness, a practical guide to surviving, healing, and thriving. Today, the learning objectives for our talk. By the end of this presentation, you'll be able to have a broader understanding of long illness from a historical and sociocultural perspective, be able to define and diagnose long COVID, understand common symptoms and conditions associated with long COVID, and describe various integrative medicine approaches that are being used to treat common symptoms and conditions associated with long COVID. If you have any comments or questions, please put them in the chat. And at the end, Dr. Adler will facilitate our discussion. As healthcare practitioners and researchers, we often measure success of our efforts by mortality. Throughout the COVID pandemic, we often look to the news to hear the report of how many people had been infected and how many people had died. Many reports focus on death. For example, in COVID, here is from the World Health Organization, over 6 million people have died in the last 2 years worldwide that have been recorded, and over 1 million in the United States as of last week. In the midst of a pandemic, it's really hard to think about the future. And so looking back, we can look at other pandemics as examples. As polio spread, they tracked cases and deaths over 100 years ago, much like they did for COVID. It took time to recognize and understand the acute phase of the disease, distribute vaccinations, and understand post-polio syndrome. Post-polio syndrome left 30 to 50% and up to 80% in more current studies of people worldwide with varying disabilities in a world that was less than accommodating. So despite lots of research for a very long time, the underlying cause of post-polio syndrome is still not completely understood. So just underline that in your brain. We might not ever totally understand long COVID, and we might not ever have a cure. So like post-polio syndrome, persistent symptoms and various syndromes developed in patients after infection with COVID-19. And while we focus on mortality at the beginning of a pandemic, polio is an example of the lingering effects of disease. Polio is also a great example of how disability from an illness can reshape society. As post-polio was not uncommon, there was increased visibility of disabled people, including a president of the United States in the center, and major gains for disabled persons were made thanks to post-polio activists. Disease communities in the last century, specifically post-polio, HIV/AIDS, ME/CFS, and now people with long COVID, have made the biggest strides for their community despite being sick. Long COVID patients coined the term for their disease using social media. The long haul, which was coined by someone who was wearing a trucker hat, they created their own virtual communities, built their own databases that have been published in peer-reviewed journals, and continue to fight for their visibility despite an initial lack of support from the biomedical community and continued public health policies and messaging that are ableist and devalue disabled lives, and systems of care that at best are not great at providing care for difficult to manage symptoms and disease. As long COVID disability turns from months to years, people are speaking up and standing up as newly disabled people. With this fresh perspective, they're experiencing the ableist medical infrastructure with new eyes, and they are shocked at what others with long illnesses and disabilities before them have been experiencing. As a disabled person myself, I'm invigorated by so many people who are coming to their disability with passionate activism, demanding that society and the biomedical model be questioned and evolve. This is great that sick and disabled people are doing this, but it's our job as practitioners and allies to stand with them, validate their experiences, advocate for them, and fight alongside in a society that continues to devalue the lives of disabled and sick people. And here are just some illustrations from Body Politic, long COVID support, and we'll provide links for them at the end. Just like we measure deaths, which is something everyone's interested in, the American Academy of Physical Medicine and Rehabilitation has created a tracker for long COVID, essentially, also known as post-acute sequelae of SARS-CoV-2 infections, PASC. We think long COVID sounds better, and we'll tell you why in a minute. And what you can see from this is in the middle here, in California, there are over 2.5 million people as of last week that are estimated to have long COVID. 2.5 million people. So just letting that sink in for a second, these are people who are going to have limitations to their work, to their life, to their ability to contribute to society. So this is going to be a huge problem both now and in the future. And so it's really important that we learn as much as we can about long COVID and continue to support efforts of these people being treated and funding happening for these groups. So when long COVID started to be reported, there was a lot of skepticism from doctors. Even in spite of the fact that there is very clear evidence, and I'm not going to go over everything in this slide, you all can come back and look through this later. There's very clear evidence that even multiple coronaviruses in the past, like in the last 20 years, that coronaviruses result in long-term health effects, including fatigue. In one study, 40% of people recovering from SARS had chronic fatigue 3.5 years after being diagnosed. So this isn't a surprise. And it's important when we talk to and about people experiencing this, that we embrace the uncertainty of these illnesses and that we continue to advocate and support patients going through this. We use the terminology long COVID. There are many different ways that people refer in research and in conversation to post-COVID illness. We use the word long COVID. It's patient-centered. There's some really great articles we encourage you all to read from Social Science Medicine, and a good BMJ opinion article from the woman who coined the term long COVID, or used it the first time on the internet. But long COVID is best able to navigate the socio-political as well as the clinical and public health challenges. We have named our book Long Illness for these reasons as well. It moves away from some of the stigma and acknowledges that many long illnesses do not fit into perfect little diagnostic boxes. It acknowledges uncertainty. It avoids dismissive terms and delegitimizing terms like post-chronic, syndrome, non-hospitalized, mild. And it shifts the attention towards morbidity. It's disability inclusive. And it affirms that not only people with pre-existing conditions can be affected by COVID. I think a lot of our public health messaging, unfortunately, has been at talking about these so-called people with pre-existing conditions. But what we understand about long COVID is that while people with pre-existing conditions might be more likely to get it, it can affect people with very mild or undetectable disease and from all walks of life, with or without pre-existing conditions. The definition of how to diagnose long COVID is pretty simple. It's anyone with symptoms for over 12 weeks. They don't need a positive test to prove COVID infection. And it's remained broad to collect as many patients with new or lingering issues. So here's an illustration from a 2021 article that shows some common or significant signs or symptoms after acute infection. And you see here, you'll have positive tests to the left. And then at week 12 to 6 months, we're still seeing symptoms, some of which are different than the symptoms you had at the initial part of the infection. Long COVID is a protracted post-viral syndrome in up to 30% of people after this acute infection, so at 12 weeks on. In some studies, up to 69%. This number is likely to change and fluctuate as we learn more and the tests become more well understood. 31% of people and 22% showed up with fatigue and 22% with cognitive impairment at 12 weeks post-infection in a very large study. It's more common in females, older patients, higher BMI, those who experienced a high disease burden in the first week of infection, and those with particular medical conditions. It's associated with over 200 symptoms. Those symptoms are possible symptoms of different conditions. Here are some of the big conditions, including like kidney disease, alopecia, that can be associated with post-COVID conditions. And I'll revisit this in a second. As I alluded to before, the list of characteristics that are more likely to be associated with long COVID a paper this month was published in Cell, and it looked for predictive factors of long COVID and found that initial viral load, prior of present autoantibodies, so those are often found in people who have autoimmune diseases, and even in patients with subclinical disease, so non-diagnosed autoimmune diseases who had autoantibodies, and people who had pre-existing conditions, including prior certain viral infections, including Epstein-Barr virus, resulted in specific groups of long COVID symptoms. And what they found was that these tests could be done at the very beginning of the illness and suggests that people who have certain markers, you can predict the type of symptoms that they will have. And therefore, you can possibly target early on with treatments that will reduce the severity or the fact that long COVID would even happen. So this is something that just came out in a trial. So this is something that we're looking at to see how to apply different treatments to these presentations of long COVID. So what do you do as a practitioner, as a friend, if you suspect long COVID? What we're taught in all practitioners of walks is that we should do a careful history and physical. And this is a case in which this is very important. Recording as much information from your patients so that they have it is paramount to guiding these people's care. You don't need a positive COVID test on record, and there's no test to distinguish long COVID from other etiologies. Gather as much data as you can. If where your practitioner can collect pulse oximetry and gather orthostatic vital signs, please collect them and record them in the chart. Initial lab tests, if not ordered at the beginning of disease for some people who had very severe disease, but after 4 weeks of symptoms, you can consider doing assessment of blood, liver, and kidney functions, inflammatory markers, thyroid testing, vitamin D and B12 levels. And secondary lab tests can be considered carefully after 12 weeks, but can include workup for markers of rheumatological disease, coagulation disorders, and cardiovascular injury. Schedule follow-ups with these patients. If you're a primary care or you work in a capacity in which you can see someone quickly again, please schedule follow-ups. These patients are falling through the cracks and they're not being heard. So just even meeting with them and checking in on how they're doing is very important. Admit uncertainty to your patients and provide points of contact. I can't tell you how many times in interviewing these patients and working in these support groups, how many times doctors dismissed or said that their people's symptoms were not real, said that it was not possible for what to be happening could be happening. At this point, as providers, it doesn't matter if we're right. We just need to make sure that we don't know the answer, and we need to just support these people so they continue to seek appropriate medical care. And also providing points of contact for them so that they don't fall out of the medical system. Reflecting back onto this list of different conditions by system, these are also kind of highlight some of the different specialist groups. And what you'll notice is this is every part of the body. Just like autoimmune diseases can affect every part of the body, so can post-viral syndromes. This is just for reference. So there are other inventories and assessment tools that might not take a lot of time for you to collect. You can send these inventories, some of them including ones that a lot of us are familiar with will probably be the PHQ-9, GAD-7, things looking for depression, anxiety. We can send these via MyChart, or we can have medical staff fill them out prior to their visit with you. And some complicated testing, like for example, a true MOCA or looking at someone's cognitive assessment might be more appropriately done by people who are specifically trained to give those tests. But if you have time and you think there's a cognitive issue, doing brief mini mental status exams and MOCAs to at least see if this is an issue can be helpful for you to decide who to send your patients to next. And also having that data recorded is helpful for upcoming providers. Other tests and tools that you can use. I think most people, even if they're not doing a visit in person, can look at exercise capacity testing in a 1-minute sit to stand test if that's appropriate for a patient. But collecting information like this and putting in the chart is incredibly helpful for other providers. Additionally, it can be helpful to, if your patient has the symptoms that are appropriate for multidisciplinary long COVID clinics, these can be very helpful for patients. We have a long COVID clinic here called Optimal at UCSF. And this sees people who are hospitalized with COVID-19 or have persistent pulmonary symptoms, and brings together pulmonology, geriatrics, and psychiatry, and most likely other groups as well. I know that Integrative Medicine was also working with them for referrals as well. Even though many clinics are popping up, some of them can be hard for patients to access. Many tests might not be covered by insurance and might be hard for patients to get to, and are not a replacement for primary care longitudinal involvement and long-term relationships with broad-based medical team. All patients with long illness need and deserve a primary care doctor who will meet with them frequently just to check in and be updated and kept abreast of the other specialists and other groups' care. For most patients, the goal of medical management. The goal of medical management is to optimize function and quality of life. This is where integrative medicine practice can be woven into your primary care or other practices. There are many strengths in integrative medicine to manage these difficult issues. Patients with post-COVID conditions will benefit from review of their current preventative care practices. This can be done by anyone. This doesn't have to be done just by primary care. You can check to see if people are up to date on their vaccinations, preventative healthcare screening, and that their pillars of health, which are the fundamentals of integrative medicine, talking about nutrition, physical activity, sleep, stress management, people's relationships, and chronic disease management, are touched on. At least just pick one. If you're a specialist or you're a care provider that might not specialize in all of these, to talk to people. And then think carefully about people listed here that might require special consideration. Reach out to other practitioners that might have specific knowledge about how to best help these groups, and refer to people with expertise in these groups when needed. We're now going to move on to integrative treatment and skills for common symptoms.
All right, thanks, Megan. Can move to the next slide. Is my image popping up for people? Maybe.
The slide is, yes.
Okay, great. All right, so treating long COVID with integrative medicine, we are using integrative treatment models that are proven effective for other conditions that are chronic or long conditions with similar pathophysiology. So conditions like fibromyalgia, CFS, ME, autoimmune disease. We're managing symptoms, addressing mental health, supporting quality of life, and improving coping. And overall, we try to suggest low risk, and that includes low wallet toxicity risk, interventions and lifestyle changes, even in the absence of concrete data. So what are these general integrative treatment strategies? The first one, as Megan talked about, is that validation and acknowledgement of uncertainty. We want to build a medical team around people so they feel supported and safe and heard. We use all the referrals we can. We love PT referrals, especially for exercise therapy, vestibular rehab for anyone who has any disequilibrium, and occupational therapy. Advocating for appropriate biomedical testing and treatment, especially when people have felt really discarded. Optimizing diet, increasing movement. We try and use the word movement wherever possible instead of exercise, because for so many people, they feel like exercise is out of reach for them, but movement is always available. We like to consider natural products. It's a question that almost every patient comes to us with, incorporating mind-body medicine and planning pain management. Next. So again, almost every patient comes to us saying, what can I take? They often come with a basket of supplements that they've gotten from the grocery store, from Whole Foods. And we have to tell them there are no supplements that have been shown in studies to treat COVID-19 infection. We do consider natural products with anti-inflammatory properties and a low risk profile. And these might include a high quality probiotic, turmeric, quercetin, adaptogens, and actually notably vitamin D. In the UK, it's actually an official recommendation that every patient after sustaining a COVID-19 infection take vitamin D. And I put the little Consumer Labs logo right next to this slide, and well, in this slide. because I've talked to many practitioners who say, I just tell patients to just pick up whatever they can, but we now have great resources like Consumer Lab that can help us to send our patients to a natural product that's going to be safe, that's going to be regulated by the FDA, and that's been proven to actually contain what is noted on the label. Next. So we're going to start jumping into some of the most common symptoms that our patients complain of and that we treat. Here I'm going to quote one of my mentors, Andy Josephson, who's the chairman of the neurology department. And he said, yeah, people say it's all in your head, and they're right. It's in your brain. And that's what we are seeing with long COVID infection. So there was a big study that came out, hundreds of patients out of the UK, a biobank study, showing that in patients who had sustained an acute COVID-19 infection, and this is not breakthrough cases, it was done before breakthrough cases, but that they sustained more brain atrophy than we would in any other common year. So for younger adults, it's about 0.2% of brain atrophy a year. For older adults, you're looking at about 0.3% atrophy. In these patients, the average was 0.7%, and it was anywhere from 0.2 to 2% of brain atrophy that was noted, specifically in limbic areas. And that's where mood is really regulated. And then in cortical areas related to olfactory senses and input. And we also see there's a number of studies coming out about neuroinflammation and this rise in autoimmunity. And I included this image to the right because it's a preprint study out of Cambridge. So I'm sorry to anyone who doesn't like preprints, but it was really striking because tau, which is a marker of neuroinflammation, you'll see in the acute phase, it goes up. In the subacute phase, it goes up, and you're waiting for it to go down, but it doesn't. It continues to rise, which suggests that there may be some degree of ongoing neuroinflammation. And this is just one of the many, many studies that suggests, as a girlfriend of mine who's a delirium researcher says, all of the badness that, and there's so many devastating neurologic outcomes that can come from COVID-19 infection. And we are concerned about ongoing neuroinflammation. But there is also some hope. There are studies showing that some of the cognitive sequelae of long COVID may not be permanent, and that patients, especially a year out, most improve. Again, we're needing longer studies, and there are certainly patients who do not, but overall, there is some good news in this. Next. So how are you evaluating brain fog? Because it's such a nebulous complaint, and people, is it cognitive impairment? Is it just encephalopathy, not otherwise stated? What is this complaint? And I think the first thing is we have to take it really seriously. People have impairment in functioning. They have impairment in their social lives, in their work lives, in their romantic lives, because they just don't feel like they can be themselves and communicate in the way that they used to and think in the way that they used to. And so the first thing we do is evaluate for any other contributions to brain fog. What else is happening with this person? And please excuse my silly diagram that is a little bit wonky, but I just wanted to lay out all of the different parts of the human body and experience that we can screen for and evaluate for that could be contributing to somebody's cognitive reserves. The brain is kind of like a bank account. And you think about, okay, what is drawing money from that bank account? Is it poor sleep? Are there food allergies that are causing increasing inflammation? I mean, do we need to really focus on brain health? Has there been a prior concussion? Are there hormone imbalances? Is this person menopausal? Are there vitamin deficiencies? Are there blood pressure changes? There are so many elements that we can look at in evaluating brain fog. We want to make sure we're screening for reversible cognitive changes, labs, the typical ones, B12, vitamin D, TSH, HIV, RPR. Screening for dementia, there's a suggestion in the literature that in older adults, COVID-19 infection may be a risk factor for increasing the risk of development of dementia. So, and that's, there have only been 1 or 2 studies. That's not gospel, but I think it's something we need to continue to just keep an eye out for. And when you're screening for dementia, you're screening for impairment in functioning and safety concerns. And then having a really low threshold for having our colleagues perform a full battery of neuropsychological tests to help us to understand someone's neurocognitive baseline and track it over time. Next. So how do we maximize neuroplasticity? These are kind of the evidence-based tenets of maximizing neuroplasticity. The first is staying mentally active, Sudoku, crossword, whatever is mentally active for you, exercise and movement, trying new things, go to a new part of the city, try a new restaurant, try a new activity, socializing. During the pandemic, people were so isolated. And so now a lot of, at least my work, is creating behavioral activation plans for people to re-engage in their social lives and connect with other human beings. And nature therapy, I'm writing nature prescriptions for people. We know even having an indoor plant has effects on the autonomic nervous system. So incorporating, indoor nature, outdoor nature time can be useful for the brain. Mindfulness, and then there's a diet that I recommend all the time because I have lots of evidence for it, and that's the MIND diet. Next. So what's the MIND diet? And is it the same as the Mediterranean diet? Is it the same as the anti-inflammatory diet? And the answer is that it includes many of the same, core elements of those diets, but has a few changes. Why do I prescribe this diet? Why does Meghan prescribe this diet? It's because the MIND diet slows cognitive decline in aging. There's a beautiful study done that shows that over time, if someone adheres to this diet compared to age-matched controls, their brain looks almost a decade younger on neurocognitive testing. So I believe it was 8.5 years was the median. And they even compared it to the Mediterranean diet in reducing 12-year incidence of cognitive impairment. And Mediterranean diet didn't do as well. And there are 2 big changes. One is the incorporation of dark leafy greens daily, and the other is incorporating berries at least 2 to 3 days per week. But otherwise, as you can see in this image, it's low red meat, low saturated fats, lots of vegetables, healthy grains, fish, and cooking with olive oil, which sounds like, the other diets that we recommend. Next. So mental health, depression, anxiety, these are very common complaints in this population. I have yet to see a patient with long COVID who isn't suffering from depression, anxiety, symptoms of PTSD from either medical experiences, ICU admissions, repeated invalidation from family, from healthcare practitioners. And there are many studies out. I thought that this one really painted a striking visual image. You'll see that the yellow line is people who have had a COVID-19 infection, and the purple line is the control group. And in this Kaplan-Meier curve, that I want us to look at that tremendous separation. So as the incidence of either having a mental health diagnosis or a prescription related to mental health, as that number goes up, that curve goes down. And it's such a tremendous gap between the 2 that shows that, of course, COVID infection leads to an increased risk of mental health problems. Next. So what does mental health treatment look like? What does integrative mental health treatment look like? Bringing in the best of biomedicine with this more global perspective. So the first is psychoeducation around inflammation, brain changes, and mood to help people to understand what they're experiencing and how this may be different from other forms of anxiety and depression. Many referrals to psychotherapy and then to psychiatry where needed. thinking about biomedical treatments that are really tailored to the person's complaints. So, if we feel like, as is happening in most of these patients, that inflammation has revved up, thinking about an antidepressant medication with potent anti-inflammatory qualities. So something like fluvoxamine is probably our most anti-inflammatory, but all of our SSRIs are pretty anti-inflammatory. And, we have SNRIs that we can use for both mood and pain. We have other antidepressants for pain. We have antidepressants that target other specific symptoms like nausea, sleep, attention. And then I really want to highlight here that we need to think about personalized dosing for medication sensitivities. A lot of our patients have they're in fight or flight, they have a nervous system dysregulation, they are terrified of biomedications, or they've had really bad experiences with SSRI side effects in the past. And we can do liquid formulations that start incredibly low and go slow so that people can have a better experience with starting on a psychotropic if it's indicated. We also have myriad natural products with excellent data in kind of conventional depression, anxiety that we can use. And the one I'm going to highlight is Selexin. Selexin is oral lavender, and it did as well in a head-to-head trial as paroxetine, one of our SSRIs, and was non-inferior to a benzodiazepine and can be used as needed or standing, and is really, has minimal side effects. So we have plenty of potent agents that we can use, natural products that we can either pair with biomedical treatments and psychotherapy or use as a standalone. And then lifestyle medicine, part of any mental health treatment plan should involve a movement or exercise prescription where possible. Next. In our group, we also focused a lot on coping. And I won't pause too much here because I know we got started a little late and we have some more slides to get through, but helping someone to understand how they cope and seeing, okay, is it mostly distraction? Is there another form of coping that I can use to help me to manage living with this new burden of symptoms? And it doesn't take much time to sit down with someone and say, how are you coping? And suggest other ways that can be helpful. Next. So fatigue, persistent fatigue occurs in most of these patients, in studies anywhere from 50 to 80%. Again, these numbers are not great. I think we're going to have a lot better data in a few years. At high risk of developing ME/CFS symptoms. And these include fatigue, unrefreshing sleep, brain fog, dizziness, but the big cardinal feature is post-exertional fatigue. So in most people, you exert yourself and you might feel really refreshed, or you might feel a little bit tired, but you're ready to get on with the rest of your day. For somebody with ME/CFS, they exercise or they exert themselves and they feel a whole lot worse. The workup is kind of a standard screening workup. And then, you can consider expanding that: antithyroid antibodies, celiac antibodies, testosterone, and cortisol, vitamin D, B12, and iron panel, just to make sure there aren't additional contributions to that fatigue. Next. How are we treating fatigue? So the first is with pacing and rest. So the best way to do this is with a referral to physical therapy for pacing therapy, not graded therapy. I just want to highlight that. Meghan has taught me a lot about the difference between pacing and graded therapy. And graded therapy, it's not really tailored to the individual, and it is not embraced by the ME/CFS community. But pacing really is more personalized, and it involves rest before physical activity and careful pacing of energy utilization, activity logs, physiologic monitoring. You can do that with a smartphone or a watch, and then avoiding cumulative over time and lead to significant flares. In terms of the biomedications we can consider low-dose naltrexone. Naltrexone is thought to be anti-inflammatory, specifically acting on cytokine production. Sleep, gosh, does long COVID seem to dysregulate sleep? And again, we can think about from a biomedical standpoint what we may have to support people, but we also have a really fabulous sleep clinic at UCSF. We're really lucky. And then there are resources like Sleepio or even CBTI Coach, which is a free CBTI app out of the VA that people can use. And also screening for emergence of other sleep disorders like sleep apnea, restless leg syndrome, or other parasomnias. We recommend always anti-inflammatory diet in these patients, and then CBT, referrals to CBT to help people to understand what's happening between my thoughts, behaviors, and feelings surrounding fatigue. Because what can happen is that as someone becomes more fatigued, their thinking can become more defeatist. Their thinking can be frustrated and overwhelmed, and their feelings can get big, as they should. It's terrible to feel this exhausted. They feel sad or resentful, scared, but then in their behaviors, they may be in avoidance, and they might not engage in the things that they need to do in order to actually treat their fatigue and get better. So helping people to really understand what's happening within them surrounding fatigue. All right, next. Oh gosh, we are running low on time. We always recommend skillful movement. Let's keep going. We'll get past that. We have a couple of mindfulness exercises we use. Long COVID headaches, migraine is more common than new daily persistent headache or trigeminal autonomic cephalalgias or other headache types. We have first, second, and third line therapies. We have lifestyle changes. We have great natural products, and magnesium and riboflavin. Every headache patient should be on those. Second line therapies, biomedicines, but also additional integrative practitioners. And then for third line, we have procedures, antibody therapy, and hospital-based treatment. Next. We love self-massage, releasing the temporalis muscle and jaw muscles to help people to break some of the cycles of tension within their face. Okay, next. This is the last symptom, and I'll have to kind of breeze through this, although it's really important. Dysautonomia, anywhere from 20 to 50% of these patients are experiencing dysautonomia. They require an expansive screening. Ideally, they go to Stanford. It's the only autonomics lab on the West Coast. But it can be hard to get into. And that testing includes tilt table, thermoregulatory sweat testing, sudomotor axon reflex testing, which looks at sweat and can help people to really get a tailored approach to their dysautonomia and the accurate diagnosis. Next. So for dysautonomia, we have a couple of principles: hydrate, movement, increase salt if other medical comorbidities allow, smaller meals to reduce postprandial fatigue and lightheadedness, compression socks, abdominal binders, if that's, again, appropriate for their medical context, biomedicines like beta blockers or medications to raise blood pressure, anti-inflammatory diet, and then mental health support to reduce some of the somatic hypervigilance that comes with dysautonomia.
And then moving forward and looking forward to wrap up our talk. So it's still really important to encourage vaccination and boosters. This can reduce the severity of long COVID and reduce long COVID symptoms. Remember, there are many clinical trials currently underway looking at various drugs, including common drugs like statins, other things listed here, and consider these in patients that might benefit as new data emerges. Low risk, low cost are the ones that you want to try to incorporate. Patients are likely going to bring these things to you, and they're going to be confusing. So make sure that you have a network of people that you're talking to and that you're teaching each other. But patients are great people to learn from in this situation. And then refer to or confer with integrative medicine specialists or practitioners to determine if different modalities might benefit your patients. When you find something helpful, tell others. I want to just touch for a second on the fact that some of these things do cost money. We talked about wallet toxicity, but I want to remind you that things such as acupuncture in San Francisco are covered by San Francisco Health Plan, which covers a lot of our patients who are at safety net hospitals. And there are covered acupuncture that is free to people who are on this plan. So it's about learning where the resources are to getting these cheap or in some cases low cost integrative modalities supported for your patients. Everyone should be supporting long COVID communities and patient groups, and advocate for your medical system to have long COVID clinics and for these clinics to be fully funded. A lot of the clinics that exist, a lot of the people that are doing this work are doing it as volunteers, are doing it, they're given a half clinical day by their departments. This is going to be a huge issue, and especially major research institutions need to put their money where their mouth is and start caring for these people who are having long COVID symptoms. We need to come up with better ways and infrastructure for this. It's not going away. It's unlikely there's going to be a cure, and we need to stand up now and start taking care of these people and funding it. And then, for some reason, there we go. There are multiple online resources for your patients, providers, and allies. Go to these websites. Body Politic is based in the United States. Long COVID Support is based in the UK. They have a lot of great resources, information, things for you to learn on. There are tons of community support groups for long COVID, for different groups of people, for people who are allies, for families who are dealing with this. This is a group of QR codes from Body Politic. You can find many of these online. If your patients are concerned that they might be in one that may or may not be great for them, you can recommend ones that are more mainstream. And then finally, we like to thank Lakshmi Santosh, from the Optimal Clinic, pulmonologist, critical care doctor here at UCSF, who when we came to her in June of 2020, talking about these patients and interested in starting a support group for them, we were just given so much support. Breeze Bell, who worked with us at the Osher Institute, now she's with palliative care, who was an outstanding long COVID doctor at Osher, and we're sorry that she has left there. And then the Osher Center for Integrative Health, we both did our training here, and especially our fellowship director and Yvette, master of all, and then the departments we trained in, neurology, psychiatry, medicine, and the division of palliative care. We're overtrained ladies, and we're proud. And then finally, our book comes out. We're excited for it to come out, and we hope that you all can check it out when it does. Please reach out to us with any questions. We know we went a little bit over. We have a short amount of time, and our PowerPoint and these slides will be available with references. And remember, everyone, COVID is not over. Keep taking care of yourself and others. All right.
Thank you both so much. First of all, can we pre-order your book? And if one of you can I'm serious about this, if you put the information, the slide went by so quickly, one of you who's not answering a question, if you could put something in the chat, that would be really helpful, the title and Hachette Press.
We will put it on on Osher's website. We don't have that information right now. I don't think you can pre-order it yet.
So thank you both so much. We've got several questions. I will ask a few, and we'll see if we can get through a few of these quickly. The first one has to do with whether you've seen any successful models of long COVID care in safety net settings.
Yeah, so as right now, I am not familiar with any. I think that a lot of these are being built. The one that's at UCSF, I think that they will see patients who come from, for example, the general, because they do not have a clinic there, but I'm not familiar with them. And I think because the safety net hospitals are already stretched so thin with resources, that's going to be a problem in building some of these. But I do think that there are a lot of people, especially at SFGH, who already practice in integrative medicine and are interested in bringing these groups together. I know that at the general, there is a post-COVID clinic that did exist, and I'm not sure if it still does, but it just is going to take some people to be interested. And I know there are a lot of people at the general who if they're not already starting one or it already exists, can build that up. And please, if there's anyone at the general who is interested in starting this, there are some amazing integrative practitioners who work at the general who I can connect you with, that trained with us, that would be great to help.
Okay, terrific. Thank you. Now a question asking for a little more detail on the impact of long COVID on sleep. So let me read here. In particular, difficulty falling asleep, staying asleep, early morning awakenings, etc. And also if there's any evidence of effective strategies for sleep-related fallout that differs from usual care, like CBT for insomnia.
What we've seen in the studies is that sleep architecture is disrupted after COVID-19 infection when people come into a sleep lab as a part of a study. We see that. In my own practice, I see certainly an increased incidence of insomnia, all of the complaints that were described, early morning awakenings. And there's been no divergence as of right now in terms of care of these patients. So it's still a low threshold for referral to sleep clinic, sleep apnea monitoring, CBTI, and then, trying to avoid, really, I want to accentuate this point, trying to avoid medications that could disrupt cognition during the day, that could increase fatigue. So, avoiding benzodiazepines, orexin antagonists, other medications that could increase drowsiness and disrupt sleep architecture. But there's a lot that can be done around sleep, but it's the usual care.
Thanks, Juliet. And now a question, let's see, given that there are no curative treatments for long COVID, prevention and specifically preventing acute COVID infections seem particularly important. Though the efficacy of mRNA vaccines has waned with the recent variants, is there data that they reduce the risk of long COVID among people who experience an infection? Is there any data on how vaccination affects symptom severity in people who've already been infected and developed long COVID?
I'm not familiar with the specifics on that data. I know that there are reports that have come out and that are going to come out, and I think that it's going to take time to collect some of this data. We do know that people from our groups anecdotally who received vaccinations with long COVID symptoms who had not, because these were the first group of people before the vaccinations, that those vaccinations did help reduce some of their symptoms or in some cases eliminate them completely. There is some low evidence that getting vaccinations can reduce the chance of you having severe long COVID. So we're seeing it the severe long COVID less frequently in those people. But again, the data is just not there yet. Shelley, was there another part of that question that I did not answer?
I think in the interest of time, we'll move on to one more question, but thank you very much. And this has to do with anything that you would like to say about long COVID in the pediatric population.
I don't know that either one of us can really comment. Neither one of us are a pediatrician or see children. Certainly long COVID exists in children. It should be taken really seriously, and they should be provided the same level of care as an adult.
There's a great website, Long COVID for Kids, that's run by the UK group, and there are lots of resources online. Of course, long COVID presents differently as children have very specific syndromes that are related to post-viral infections that we don't see as much in adults. And so I would refer you to those. There's great resources online.
Okay, terrific. We have several more questions that we're unable to get to, so I want to thank you for your generosity in sharing your email addresses and encourage people to contact you directly to get those answered. And in the interest of at least ending on time, and apologies for not beginning on time, thank you both so much. It's difficult to think of a more timely and important topic. And your rigorous, robust, and integrative approach is really critically important. So a pleasure to have both of you teaching us this morning, and I invite folks to applaud virtually in their hearts or on video. Thank you very much for your time with us this morning.
Thank you so much. It was great. We really enjoyed it.
Thank you. Thanks, everybody. Take care.